So very good afternoon to everyone present. Again, thank you so much for taking time out of your schedules to join us today for today's talk on use of NIPS. And hopefully by the end of today's session, all of us involved would have a better understanding of how it should be applied in prenatal testing and what is its role essentially in prenatal testing. Good afternoon everyone, I am Dr. Sam Balu. By profession, I am a molecular geneticist and I am the Assistant Lab Director at Eurofins Clinical Genetics. Okay, thank you very much. So to start off with, before I get to the actual topic at hand, since we are going to be your service partners, and I do mean that term partner in every sense, that we would like to work with you, learn from you, and help the patient better, I would quickly summarize our philosophy as one of empowerment. It's not a very scientific term, but we would like to apply it in a scientific context. And who are the main stakeholders in this triangle of empowerment? Us, you, and your patients. And what do we want to do? Essentially, we want to empower you, the clinicians, and your patients to make better informed decisions through diagnostic testing. But this is a mouthful. Perhaps there's a simpler way where we can communicate with you and as well as your patients. Simply put, help us to help you to help them. And how do we actually want to do this? So we have end-to-end genetic testing solutions with us at ECGI. And what do I mean by end-to-end? I mean even from preconception, not just prenatal, all the way to pediatric and adult, we offer a wide array of tests, not just type of tests, but also a variety of platforms, whether it's karyotyping all the way to cell-free DNA analysis using NGS. And in today's call, it's very interesting. We'll be talking about karyotyping also and cell-free DNA analysis using NGS as well. So going ahead, is there an actual need in Indian context to study aneuploidies? Very much so. If you look at the data which is shared by Dr. I.C. Verma from Gangaram, there is an incidence across the board for malformations, chromosomal diseases, Down syndrome, which all of us expect, as well as quite interestingly trisomy 13. And please note that point of trisomy 13 from Dr. Verma's data, because later on when we are doing some case studies, this holds a particular importance. So there is conventional prenatal genetic testing done. Typically in the first trimester, most of the patients would undergo the nuchal translucency scan and double marker, but all of us in this call and in the market in general are aware that conventional testing generally has limitations. It's quite operator dependent. It is biochemical assays. So essentially what you're trying to do is look at a change in chromosome number by looking at a biochemical change, right? It has a high false positive rate. Now positive rates are somewhat okay because it's a screening test and you would later confirm it through invasive testing. But the problem is also without combining the double marker with nuchal translucency, the sensitivity of the test itself comes down. So what then you are dealing with is actually false negatives, which is a huge concern and also a liability. What does NIPS have in terms of its global impact? The Indian scenario and the Indian market is slightly different, and I will touch upon why that is different, is that since the induction of NIPS and its mass acceptance across the globe, you see that the need for invasive testing has significantly dropped. That means this now across the world is becoming a frontline screening test, NIPS. Of course, in India, unlike many Western countries, NIPS is not supported currently under insurance. So what happens is your clients, the patients, would be paying out of pocket. So generally in India, the prescription is we look at the first trimester markers and we look at NT and DM generally. And if you're getting high or intermediate risk, then you prescribe for NIPS. Or if there is family history, then you prescribe for NIPS. This is the current trend. But hopefully the Indian government and few state governments also seem to be taking initiative to allow this to come under the aegis of insurance, which would make everybody's task a lot easier. What is NIPS in a nutshell? So it is non-invasive prenatal screening. Please remember, this is a screening test for fetal aneuploidies. using cell-free fetal DNA or placental DNA. I'm emphasizing that again and again is, remember, this means that this test is slightly susceptible to placental mosaicism. Okay, and it is found, you are going to analyze this DNA from maternal blood, which already contains a mixture of both cell-free fetal DNA as well as cell-free maternal DNA. Cell-free maternal DNA plays an important role in NIPS. Please keep that in mind. So who are we prescribing NIPS for? For a wide gamut of, wide variety of reasons. It could be advanced maternal age, conventional markers are showing high or intermediate risk, and this could be second trimester markers as well. It need not always be first trimester only. There is positive family history, you have an affected child, or you have a previous pregnancy loss with known chromosomal aneuploidies. It could be, okay, there was a pregnancy loss, we send a POC for karyotyping or POC for microarray, and we found that it was trisomy 21 positive. So in such cases also, NIPS gives you a very nice non-invasive alternative. And lately, thanks to the widespread use and widespread knowledge available with the patients, you have a lot of patients who are anxious, and they say that, look, I know that there is low risk, my double marker is fine, my NT is fine, I still feel anxious. Do you have a more sensitive test than that? The answer is yes, we do in NIPS. And for IVF patients where you're dealing with a lot of precious pregnancies, these are people who are struggling to have natural conception happening. So when you have precious pregnancies, when you have embryos which are all aneuploid or mosaic aneuploidies, and as a doctor you decide, okay, with the appropriate counseling I'm going to transfer a mosaic embryo, NIPS gives you a very nice solution to screen it as a follow-up. Fetal fraction is critical in NIPS. Fetal fraction simply means this allows you to know how much cell-free fetal DNA is actually being analyzed. And if you look at the next line, I will not get into that too much, it represents the formula. This is mandatory and must be reported. So if any service provider or partner of yours is giving you a NIPS test without the fetal fraction being displayed, you can reject that test or ask them that it is mandatory, it is government mandated that fetal fraction should be displayed. And why it is so important is simply because this tells you that the test was analyzing this much DNA to give you the interpretation. So all NIPS tests have different limits based on a wide variety of factors like what is being used, and generally the range is between 4 to 2%. And there's a constant, we strive to work and bring down the fetal fraction percentages so that we can work with even lower fetal fraction cutoffs. In fact, I'm very proud to say that Eurofins has validated its NIPS for different types of tests, especially if we look at our more advanced NIPS at 2% fetal fraction. So we have developed it, validated it clinically. Precautions when you're actually going to prescribe NIPS. Are there certain cohorts of patients where you need to take either precaution or outright you do not want to think about prescribing NIPS to them? The answer is yes for both. So if you're looking at T21 positive mothers, there we do not recommend prescribing NIPS. Simply because what happens is, because the mother has also an extra copy and it's a ratio based analysis, the algorithm will go wrong in analyzing it. Therefore, we don't recommend T21 positive mothers, you go for NIPS, rather than that you can go for direct invasive confirmatory testing. Bone marrow transplant patients also, at least for 21 days after transplantation, please wait. Why? Again, you're looking at peripheral blood analysis here from the mother. So you want to have this window period so that the body reacclimatizes and you get the correct ratio of both the cell-free fetal DNA as well as the maternal DNA. For pregnancies of higher order than twins, please be careful, because currently the software across the world is meant to deal with the twin pregnancies only. If it is a triplet or any higher order, again the test would fail. So please make sure that in case of twins, it is actual twins, and if in case it was a higher order pregnancy and one of the twin has vanished. So a lot of you would get cases of vanishing twin. This is very commonly seen in IVF pregnancies where multiple oocytes may be transferred or multiple embryos may be transferred, apologies, and then one twin will disappear. What we recommend is waiting at least 6 to 8 weeks, because this window period is required such that the vanished twins' cell-free DNA actually disappears from circulation. So what happens if you do it before this is you tend to get false positives. Because here what would have happened? The twin who has vanished most likely has vanished because of an aneuploidy, and that will skew the test towards giving a false positive. We recommend 6 to 8 weeks to wait to clear for the vanished twin. However, in cases of emergency or if they're coming late gestational age, we can always counsel that there is a chance of this, and if they say go ahead, then we can think about it. But recommended 6 to 8 weeks. And other rarer condition is when the patient, the mother, is on drugs like anticoagulants, and I'm not talking about mild anticoagulants, I'm talking about combination anticoagulants or cytotoxic drugs. Generally pregnant mothers are not on that, or if they're on that also, the dosage would have been titrated down for them. At least you need to monitor it, and you need to look at reducing the regimen before at least 3 to 4 days of blood collection. So why does this impact the NIPS test? I'll go back a slide with all your permission. If you look at this ratio here, this is a very, very important thing. Cell-free maternal DNA. So any kind of activity or drug which increases the cell-free maternal DNA in this ratio will actually suppress the fetal fraction percentage, right? So fetal fraction percentage between 4 and 2%, somewhere in that range, if it is there, we can start making the calls. But what happens if this particular value goes up is the fetal fraction percentage actually gets suppressed. So you have this problem not only in people who are on anticoagulant or cytotoxic therapy, drug therapy, but you also have this in people who are morbidly obese or have a skewed BMI. These are things which to keep in mind. It doesn't mean that everybody who is having a BMI skew will have this NIPS test failing, but it is something to keep in mind that this could be one of the causes. Okay, and generally what will happen in such cases is you will get fetal fraction is below detection limit. So we cannot do further analysis and report it. Right, so there are different types of NIPS available. I will be focusing on the methods which are used. So there are two methods of doing a NIPS analysis. One is called the MPS or counting method, and the other one is called the SNP SNP method. Okay, currently in the world there's only one company which is offering SNP based NIPS. SNP based NIPS has its own advantages, but by and large for the clinical community it has a lot of disadvantages, especially the ones which are being highlighted right now. If you look at the redraw rate in MPS or counting method versus SNP, the SNP method, because I personally worked with this, has a higher redraw rate, and it used to be quite alarming for us when we were working because it will come 4% fetal fraction, 6% fetal fraction, no call. 6% fetal fraction, no call. Imagine what that happens to a patient and to you when they're at 18 weeks, you have given your second sample or a redraw and it comes like that, 6% fetal fraction, no call. Now the patient is stuck, you are stuck, twice the sample has been done, the patient is anxious, they're waiting for it. So we by and large have evaluated both systems and seen that the counting or MPS stands for massive parallel sequencing, SNP stands for single nucleotide polymorphism. Okay, these are two different approaches to doing NIPS. But importantly, both approaches have got very good sensitivity, specificity, low false positive rate, low false negative rate as well. Only one more thing in the SNP method is usually it requires a larger amount of the actual sample because its filtration and analytical process is more, I would not say stringent, I would say more skewed towards eliminating a lot of reads. So you require more blood for doing SNP based NIPS. What we currently offer is we offer an entire gamut of testing. We have two different basic NIPS methods available, right? And we also offer advanced testing. So these are two different methods we use for doing the basic standard NIPS. Both are equally good in terms of sensitivity, specificity. We have a low cost version of NIPS, which is called the Eco NIPS. And if you see, they both require the same amount of blood. And please remember, the basic NIPS only takes care of trisomies in 21, 13, 18 and sex chromosome aneuploidies, and it does not detect microdeletions. And also what happens is this particular NIPS can be used for natural pregnancies, IVF pregnancies, donor pregnancies, twin pregnancies, and twin pregnancies of donors type also. So this is going to be common across all types of NIPS. So these two are our basic or standard NIPS offerings. This one is just that it is a low cost alternative for those patients who have issues with affordability. Then we also have the Prenature NIPS Plus. Now this is a very interesting test because it also screens for 5 common aneuploidies, and this test, please remember, along with the aneuploidies, along with the aneuploidies, it also checks for 5 common microdeletions. And this particular test, I would like to emphasize, is having these microdeletions which are clinically validated. Because I'm aware in the market there are a lot of service providers who say, look, I do 40, 50, 60 microdeletions. Then you need to ask them, look, of these 60 microdeletions, which are common ones you'll find in the population? Second, is your particular test validated with clinical samples for these microdeletions? Very often you will find the answer being no. So these are clinically validated microdeletions which we have developed, and we have a very high sensitivity and specificity for this. Next, we also offer a type of NIPS. If you're getting confused, the Karyo here still means NIPS. So here what we do is we offer NIPS for all chromosomes, or what are called rare autosomal aneuploidies. And are these important? Yes. How to use this particular test, I'll be touching upon more in detail later. The last one is our most advanced type of testing, wherein in addition to doing all chromosome analysis for aneuploidies at 7 MB resolution, we can also offer 8 microdeletions, again clinically validated, for all the particularly common types of microdeletion disorders. And very interesting is, for all the prenature tests, we have done clinical sample validation at 2% fetal fraction cutoff. So 2% and above, we are able to do aneuploidy calling, microdeletion calling, we are able to give aneuploidy calling for all chromosomes, and we are able to give aneuploidy calling for all chromosomes plus 8 microdeletions. So that is, when we say we have the most comprehensive portfolio for doing NIPS analysis, this is what we mean. Afzal, I'm not sure whether you meant audio or auto. Please try rejoining if it is auto disconnection on your side. Apologies for that. Right, I'll move on to the next slide. So our experience essentially is Eco-NIPS is a relatively new test. So we have around, I would say right now, around closer to 260 samples we would have. I would just put a ballpark figure of 200 plus. On the NIPS, we are closing on 3,000 samples. On the NIPS Plus, we have around 250 samples. Because you would see NIPS Plus, Karyo and Karyoplus, the more advanced test, the prescription requirement is quite low as compared to conventional NIPS. But of course, we would like to say that those tests need not be ignored. In fact, they should be strongly considered in particular types of pregnancies or particular risk factors. All of them have got pretty much uniform sensitivity and specificity. Generally, false positives in NIPS tend to be monosomy X or XO. This is more due to placental mosaicism than anything else. And false negative rate, in our experience so far, we have not got a single false negative. The recall rate is also extremely low, and generally you get that due to low fetal fraction. And I need not tell you, you would be more aware that in the Indian context, you see trisomy 21, trisomy 13 and trisomy 18. Again, please remember here, we see trisomy 13 more commonly than trisomy 18. This is in our experience. And all these tests have been validated on clinical samples. For those of you who are wondering, the prescription row there, the DM stands for double marker, the QM stands for quad marker, USD stands for ultrasound. So if you look at it, you get a general idea, but do not worry about that. I have dedicated slides which talk about how to decide which NIPS is good for you. In fact, before I go to that, I would quickly take a minute break, and I would request if there are any doubts so far, or if there are any queries, or if you would like me to repeat anything, I will be happy to. So I am safe in assuming currently there are no doubts with anyone. Any parts? How many clinical? Okay, yes, ma'am. So generally what we do is we take around 200 to 250 samples for us. And what we do is, along with our samples, we have a lot of sister concerns across the world. In fact, for developing the Prenature Karyo and Prenature Karyoplus, we worked very closely with a lab in Italy called Genoma, and we took their samples as well. And we did it with 250 samples of ours plus 250 samples of theirs. So we done a 500 sample cohort for validation of this, for all these tests. And of course, whenever you get a new NIPS test, you need to validate it in minimum of 100 samples, at least 100 samples, which by and large is done by the company who's supplying you the instruments. But we don't limit ourselves to that. We take more, because we say, okay, 100 samples is nice, and these are Asian samples, Asian this thing, but no, we also have plasma of Indian samples which we use for validation. So all our tests are generally validated in between 250 to 100 samples. Sorry, 250 to 500 samples. So choosing the right type of NIPS is something I would like to spend a little more time on. So the standard NIPS, of course, you're looking at age-related risk, first trimester screening risk. You have the second trimester also, where it's showing aneuploidies. Again, it's specifically for aneuploidies, because in NIPS, you're essentially looking at changes in chromosome number. And depending on which NIPS you choose, you're also looking at which chromosomes. So please understand, if you're looking at some other chromosome beyond 13, 18, 21, you may want to think about using a karyo rather than just a standard NIPS. And also, if you have positive history, that is previous children with, or pregnancies with Downs, Edward and Patau confirmed, you would want to do that. And if you have family history, it need not be the mother whose sample you're sending us, but there's positive family history where you have Downs, Edward and Patau, you would want to think about prescribing NIPS. And this holds good across the board. When you're looking at NIPS plus, you're looking at ultrasound abnormalities which could possibly indicate microdeletions. And one of the ones which you're looking at, the most common global microdeletion, global prevalence wise, is DiGeorge, or 22q11.2 microdeletion. This is something which you can pick up even in the USG. You have previous pregnancies or a previous child with these microdeletions and positive family history. Again, coming to karyo, if you're looking at aneuploidy risk, age-related, and here we very, very strongly recommend considering karyo and karyoplus for precious pregnancies. Pregnancies where you have a lot of previous miscarriages which are repeatedly come positive for chromosomal aneuploidies, and you generally find those chromosomal aneuploidies do not tend to be that much 13, 18, 21. They can be other chromosomes as well. What are known as rare autosomal aneuploidies play a role in recurrent miscarriage. So you can look at that as well, and that's what is highlighted in the next point. And if you're looking at IVF pregnancies where they want to be doubly sure or triply sure that there is no other chromosomal aneuploidy here, and especially in IVF pregnancies where there's a mosaic embryo being transferred. For those of you who are not aware, a mosaic embryo is one where some of the cells are aneuploid, but the remaining cells are euploid. So anything between 20 and 50%, if there is no choice, the IVF clinician, along with counseling, saying that, look, among the 6 embryos we have developed here in IVF, none of them are truly euploid. None of them have exact chromosome number. All of them are aneuploid. But in that, based on the guidelines, we have selected that this particular embryo is having the lowest risk of miscarriage or having an abnormal or affected child. We would like your permission to go ahead and transfer these embryos. And it is done in India. Mosaic embryos, along with the consent of the patient, are actually transferred in India. So in those cases also, rather than going for an invasive confirmatory test, you can also think about doing NIPS, and specifically NIPS karyo. And if you're looking at even more advanced version, where again the patient really wants to rule out most common things and even rare autosomal aneuploidies, you can always look at using Prenature Karyoplus. Again, I would like to reiterate that these choices are available with you, and this is just a guideline for trying to decide. It's not that you're only limited to using the standard NIPS or the NIPS with microdeletions. You have 2 more tests available with you here, which you can also consider for certain pregnancies. Is there a benefit actually? So this is a cohort study which we did with the Italian uh, partner of ours known as Genoma. And what he found very interestingly was that 16.9% of the samples we analyzed, in that rare autosomal aneuploidies also were there, including unbalanced translocations, deletions, and microdeletions. Again, please remember this 2.9 microdeletions comes from Karyoplus, right? And we were able to actually pick up these as well. And most of these cases, interestingly, had previous miscarriages and other abnormalities in ultrasonogram. Generally, the earlier pregnancies also did not survive, and a lot of them were also IVF pregnancies. So there is definitely a role to be played by these two advanced tests, and this is some of the data we have to showcase the same. Coming to microdeletions in general, because even now the ACMG guidelines don't have any particular mandate for microdeletions. So if you get a microdeletion positive case, you cannot look at AOCG or ACMG as to what is the guideline. So a lot of doctors in India consider that, look, should I really do microdeletion testing or not? So this is some interesting data which I'd like to share. And essentially, is microdeletion testing, so is microdeletions, are they more common in Indian population than others? Ma'am, I would say that right now the data we have is quite inconclusive, but interestingly what happens is a lot of these microdeletion pregnancies do not in fact come to term. So microdeletion positive children, I do not have sufficient data to make a call compared to global statistics, but interestingly for trisomy 13 there is something which I would like to discuss. So currently, ma'am, I don't have the Indian data versus global data for microdeletions, but yes, we do get cases of DiGeorge, which we very often confirm. For DiGeorge, we do have some data, but again, I would not want to venture a guess based on the current data I have. So interestingly, if you look at that, which I was talking about, after T21, if you look at global prevalence rates in 100,000 live births, you have the DiGeorge microdeletion actually being the next most common. In fact, even more common than trisomy 18 and 13. So people with DiGeorge, this is the one where you have a lot of chance that the pregnancy will come to term and the child will be born with the abnormality. It's quite interesting. And of course, if you look at the global data, it puts trisomy 18 and trisomy 13, but in India you see a reverse trend. You'll get a lot of cases with trisomy 13 coming positive and not so many trisomy 18s. It's quite interesting in India that way. So, is there any substantiative data to say that, look, is NIPS testing for or NIPS screening for DiGeorge really worthwhile? So, we'll just isolate our discussion to DiGeorge and look at the data. So, they have analyzed in this particular study close to 22,000 samples. And if you look at their assessment, they actually look at a rate of almost 1 in 1,000. So if you look at the cohort, they've studied almost 22,000 samples. They report an incidence rate of 1 in 1,000. And why they have such a high rate as compared to the live birth rate is that a lot of them may not survive and come to term. So when they did an analysis using NIPS in 2016, they found that actually 1 in 1,000 rate is there. And after this paper had come out, they had revised the incidence rate as well. Earlier it used to be 1 in 4,000, it came to 1 in 2,000. So if you look at it, what happens here, the microdeletion syndromes have an impact on the patient. They do have an impact on the patient. It might not be in terms of always reduction of lifespan, but you do get other abnormalities, including things like seizures, cardiac abnormalities, growth defects, dysmorphism. Usually you get some form of MR or autism-like symptoms. So these are all things to consider when you're prescribing for NIPS with microdeletions. So I'll be moving on to the case studies. I hope so far in our discussion, we have some clarity on what are some of the different types of pregnancies which need to consider for different types of NIPS. And in case of precious pregnancies where you have bad obstetric history, it's an IVF where there's multiple cycles have failed, you may want to consider things like NIPS Karyo. and NIPS Karyoplus. So this is an actual clinical case. And again, I would take a 1 minute pause here. If there are any other questions, please do ask me. And again, if there's anything you would like me to repeat in the previous slides, I'm happy to go back and repeat it. I'll take a 1 minute break here and I will let you ask your questions. We have a question in terms of the sensitivity for sex chromosome aneuploidies. So in terms of sensitivity for sex chromosome aneuploidies, currently our NIPS is we are at 92%. This is our internal validation data. We are at 92%. And like I said, the most common false positive you'll get for sex chromosome aneuploidies is XO. And generally we rule it out with fission karyotyping or through microarray. The most common false positive we have come across in our experience with those 3000 plus samples is XO. Jaideep, yes, certainly that can be shared. There is no objection to that. So with your permission, I'll continue. So our first case was a 36-year-old female, and she just had risk of advanced maternal age. Sample was sent for our premature NIPS. And this is a typical case. I thought I'll start off with a very, very clear-cut case where, we had this particular thing and where we showed that it is aneuploidy detected, and we give our interpretation saying that result is consistent with trisomy of chromosome 21. We say it is consistent because why we use that particular terminology? Ultimately, it is still a screening test. Why is it a screening test? Simply because you are indirectly analyzing the circulating cell-free fetal DNA, placental DNA from the maternal blood. Okay, and did the invasive confirmation actually bear fruit? Yes, we had a classical trisomy 21 karyotype here. So this was a case where we were able to report it and then later confirm the same case. Joy, you repeated your question. The answer still remains yes. Next case, interesting, again, this was at 12 weeks gestational age. We opted for premature NIPS. This came with a slightly different result, which is quite interesting for everybody today. So here, if you look at chromosome 13, it doesn't say aneuploidy detected or no aneuploidy detected. It tells you something in between. It says aneuploidy suspected. And it tells you that we actually put this thing saying that result is not interpretable for chromosome 13. What does this mean? We cannot tell you for a fact that this is positive or negative in terms of its screening for trisomy 13. And generally what happens, there can be two causes for this. One is if there's placental mosaicism. The second one is there is actual fetal mosaicism, true fetal mosaicism. And generally you see placental mosaicism manifesting, again this is purely on our experience, in sex chromosome aneuploidies. You don't see it too much in 13, 18, 21. So interestingly here, we went for a fish and KT combo. And what happened is, when we analyzed the 40 nuclei initially, we found 38 out of those 40 to have the normal chromosome number. You can see chromosome 13 in 2 copies there. Interestingly, you had the partial number of cells here showing trisomy 13. So this was a case of true fetal mosaicism. And I remember this case quite clearly because something very, very interesting happened with this and the next case, and they came in the same month, that is last year August. Both these cases had come to us. So this was one where we were able to pick up through NIPS, I repeat, through NIPS, a 5% true fetal mosaic for trisomy 13. This is a 5% mosaic. And what happens here is actually it sits at the cutoff for fish test. So this is a 5% fetal mosaic for trisomy 13. We were able to pick up and report in NIPS. And interestingly, when you do the karyotype for this, depending on which cells get metaphase, all the karyotypes we got were all normal. Because it's only a 5% mosaic, we were not able to actually look at it in the karyotype. Now, this is all well and good for as a geneticist to talk about this, but what next? What about the patient? What happens here? Because we delivered the report, now the report is with you. You have an answer saying, look, it's a 5% mosaic. Should this be considered or not? So what happens in such cases where you have a mosaic result, which is confirmed, the genetic testing takes on a more supportive role here. And then as clinicians, you would be looking more in depth at your ultrasonograms, your other markers, and you may want to schedule advanced fetal anomaly scans, which was actually done in this case. And what happened is they decided to continue because trisomy 13 symptoms. Yes, Dr. Aradhana, you can recommend NIPS for those with advanced maternal age. It is a very good screening test for them. So what happened here is, based on the ultrasonogram findings, they were saying that there are no more features developing. They went for an advanced fetal anomaly scan, and then they said that, okay, we would like to continue with this pregnancy. And in fact, this is an ongoing case with us. Interestingly, in the same month, we got another case. Again, she had an age-related risk for trisomy 21, and she opted for going for the eco-NIPS. Now, the eco-NIPS gave us a 13.3 fetal fraction, and it said high risk further investigation is recommended again for trisomy 13. So interestingly here, I currently don't have the FISH KT data, but we found that this is also a mosaic. But unlike the previous case, this ended up being a 10% mosaic. So here again, what happened? They went for an advanced scan, but unfortunately for the couple in this pregnancy, they were able to see the initial ultrasound abnormalities beginning to develop, which were associated with trisomy 13. So the parents decided not to continue with the pregnancy. But again, we were able to pick up even a 10% and 5% mosaic trisomy 13 using NIPS. It is that sensitive and it has that good detection rate that even though it was only 5% of the cells in the fetus, we were able to pick it up. This is actually an Italian case which was from Genoma, where the NIPS showed an abnormality of duplication on chromosome 7. It was quite a big duplication. It's 15 megabases in size. And later, when the region was analyzed, it was found to be associated with autism spectrum, hypotonia, dysmorphism. And when the microarray was done for this patient, it actually showed the exact same region on chromosome 7. If you look at it, it's chromosome 7p22. You can see that region here, and that particular region also showed abnormality in the microarray. Right, Dr. Soumya, so even if your double marker and quad marker are coming negative, but you have some other markers like advanced maternal age, you have ultrasound abnormalities where you are strongly suspecting an aneuploidy, or if you have previous history, obstetric or family history, which you would like to consider for aneuploidy screening, NIPS is a very good test. So it is not that only in DM, intermediate or high risk you need to do this, you can do it even in the low risk cohort. If there are other markers you would like to consider, or sometimes very simply the patient might want to do it or they're extremely anxious, you can say, look, this is another test we have available which has more sensitivity than the DM and QM alone, and you can take it up. Especially for the QM, if you're looking at aneuploidies, the NIPS carriers are very good options for that. So yes, and in fact, like I showed you globally, in fact for double marker, this has kind of taken over the position of double marker abroad. So their first level of screening is your NT, and then they immediately go for the NIPS rather than going for a double marker state. In India, since it is out-of-pocket expense for the patient, a lot of clinicians would consider doing a DM first, but yes, this can be used in such cases. So this was a case where you had a rare autosomal aneuploidy, a duplication in chromosome 7, and that actually later was confirmed with microarray. So is there some kind of decision matrix we can develop which would make it a little easier for you, or just as a guide for you to consider which kind of NIPS to be chosen in what condition? So you're looking at all the various factors here. At the primary screen, you look at maternal age, ultrasound, biochemical markers. In addition to which, you're going to look at things like family history, obstetric history, and you may even want to consider pregnancy type, whether it's natural or IVF. Although that is not such a great factor, but it's something you need to consider as well. Because you will be looking at pregnancy type for things like vanishing twin and other cases. Right? So we have a positive indicator somewhere, whether it's family, obstetric, maternal age, or biochemical ultrasound, but you have no other risk. No family history is there, or no other essential risk is there for, especially for microdeletions, then by all means the most common one can be chosen, NIPS. If on the other hand you are having a risk for certain specific and commonly occurring microdeletions like DiGeorge syndrome, so in the ultrasound you are looking at some abnormalities developing, there's some cardiac abnormalities, possible sign of a cleft lip or cleft palate developing there, and you want to look at specific microdeletions, you can consider NIPS plus. And one point which I'd like to emphasize is microdeletions, unlike aneuploidies, are independent of maternal age. We have got cases of mothers being below 30. They could be 26. We have a case of 26-year-old, 28-year-old. All of them have tested positive for DiGeorge in NIPS, and they have been confirmed DiGeorge cases. So this is something to remember as clinicians, that unlike aneuploidies, microdeletions occur independent of maternal age. So if there's any family history or any other indication, or if you're suspecting a possible microdeletion, please do look at NIPS plus or Karyoplus. So here you have a precious pregnancy, or you have positive history for other rare autosomal aneuploidies, and you want to look at screening all the chromosomes here so that you don't miss out even the rarest of rare aneuploidies, you can choose Karya. If it's a similar case where you have a precious pregnancy but you have family history for microdeletions as well, you can think about using Karyoplus. So I hope this is clear for everyone, this particular matrix. And again, this is just a guide. By no means are we saying that you need to pick one or the other, but just saying that you have more choices with you than the routine NIPS or the NIPS with microdeletions. You have two more alternatives which would do additional chromosome analysis. Can we replace double marker by it in all our IVF pregnancies? Yes, Dr. Aradhana, that is something you can consider, especially if it is you have IVF embryos. Yes, it is something which you can look at as a standard screen. That is something you can actually consider for this, because its sensitivity specificity is quite good. So that is something definitely you can consider for this. So the IVF embryos especially, this is something where you can see, okay, now NIPS as a routine screening method. In fact, we have a few doctors in India who are already adapting NIPS Karyo for IVF pregnancies. And they are getting quite good results with that as well. So that is something which can definitely be considered. So I will actually give a couple of examples, and I would like somebody to give me feedback either through chat or unmute yourself and tell me. For example, one, we have a 36-year-old female, double marker and nuchal translucency shows intermediate risk for trisomy 21. When you look at the family history, there's no positive family history, there's no previous child with Down syndrome. Obstetric history is normal, it's a natural pregnancy, and just to add it, say this is the first pregnancy, so don't have any other obstetric history. What kind of NIPS would you recommend here? Dr. Chopade, no, sir. Is it this? Are you asking me for this slide, sir, or for a previous one? Oh, when you say what do you mean by a T20? So she is a Downs carrier. She is positive for Downs, or she is mosaic Downs. So that would be when you would not recommend NIPS, sir, because the NIPS is based on ratiometric analysis. So definitely what will happen is she is already having an extra copy, either all cells or some of the cells, that would skew the analysis. Dr. Shefali, you are absolutely right. What we would generally recommend here, based on the decision matrix, since it is only intermediate risk, there is no history and everything else seems to be normal, the ultrasound is normal, you would go only for standard NIPS. So I would move on to the next example here. You have a 32-year-old female, again, no advanced maternal age. Ultrasound is showing abnormalities which could be associated With some other aneuploidies, rarer aneuploidies, it is an IVF history, your obstetric history is poor, you have 2 cycles which are failed. And interestingly, please pay attention to the next point, that's an interesting one. The sister's child is diagnosed with Angelman syndrome. I hope somebody can tell me which chromosome is involved in Angelman syndrome, and is it an aneuploidy or is it a microdeletion? I hope someone can let me know. This would help you decide which one should be used. Right, I do have an answer. With your permission, I'll proceed. Correct, it's a chromosome 15 microdeletion. So you have positive family history of microdeletion. It's a precious pregnancy. Its ultrasound is showing abnormalities which can be associated even with other chromosomes. So here, what do we decide to do? Here you have advanced maternal age is negative, but you have intermediate risk, and then you have positive obstetric history, family history, it's a precious pregnancy. So here definitely what you would recommend is Karyoplus, because you're looking at microdeletions here, family history, rare autosomal aneuploidies, and it's a precious pregnancy. So you want a test which can give you the best possible screening for all these conditions in a single test. So Karyoplus would be the test of choice to be considered for recommendation. Right. So this is just 2 examples, and I'm sure if you go through your cases, earlier cases and cases which are coming, I think this would be useful. And what I would really appreciate as a service partner with you is you say, Sam, look, I want you to tweak this. I want you to change this. I think this parameter also you should consider, or this parameter you should, change or edit. I would be the happiest person to get your feedback. And as an organization, it would be our privilege to learn from each and every one of you on today's call, how to change this. Because for us, that's why I always say we are service partners, not service providers, because for us, it's a learning experience. And anything that can help us, help you, help them, we are happy to adopt and adapt. Okay, so Dr. Soumya is asking, what is the gestational age for doing NIPS? So essentially, you can do it as early as 9th week of gestation, but generally what happens in India is you're waiting for your DM and NT. So you're doing it after 10th week, 11th, 12th week onwards. And in 9th week, what happens is your fetal fraction is low. So if there is something like BMI being skewed, there's a higher risk of low fetal fraction calls coming. I'm not saying it's in all the cases it will happen, but there is generally an increased risk of low fetal fraction coming in cases where there's a skew of the BMI of the patient. But 9th week onwards it can be done. Is there an upper limit? No. There is no upper limit for doing NIPS. So we have got cases both from India and as well as abroad where it's being done at 23rd week, at 24th week. And these patients, obviously in India, you have the certain guidelines from PCP and DT, and they are counseled and they're told, but still they want to do it. They're saying, no problem, I want to know. We had with your permission, there's a very, very interesting case of an IVF pregnancy where trisomy 21 has come positive. Right? The trisomy 21 is positive in this case in terms of NIPS. We confirm trisomy 21 through karyotyping and FISH. The mother then decides, no, I will continue with this pregnancy. It's an Indian patient. Because she says, look, Sam, this is the last batch of oocytes I have. Right? And we tried, and this is the only one which has implanted. And the pregnancy is ongoing. I understand the child is going to have Down syndrome, but we choose as a couple to continue with this pregnancy. So we see cases like this also. In India, we have a saying, rare is not so rare. So this is one of the examples we saw. Actually confirm NIPS results, a majority of you would say immediately go for karyotyping and FISH. It's a very, very cost-effective test. It has a quick turnaround for FISH and it has a moderate turnaround for karyotype. But if you look at this particular table, there are certain disadvantages in doing karyotype, which I'm highlighting. I'm by no means saying that don't do karyotyping and FISH. You can consider it, but always remember that there are certain disadvantages. First and foremost, it's a cytogenetic test. It's the gold standard. Yes, absolutely. But you do have molecular tests also available, which can do a very, very highly sensitive and specific analysis, namely the microarray. So microarray is also a confirmatory test. You don't need to recheck a microarray data with any other test. So a microarray now is also a confirmatory test. And remember, it's a DNA based test. And microarrays now have very quick turnarounds. So within 5 to 7 working days for a prenatal sample, you can get results. At max, it would take 14 days or 10 working days, which is kind of similar to what you will wait for anyhow in karyotyping. Fish results will come in 3 to 4 working days or 5 working days to you, but you still need to wait to confirm with karyotype. Right? Whereas in the microarrays, 7-10 working days maximum, you will get your results, and it's a direct confirmatory test. Very important is that since it is a cytogenetic or cell-based test, cell culture is required. So if there is cell lysis in the sample or your amniotic fluid has got very low cell count, it is very difficult to get the cell culture established. Sometimes they will have to go for repeat cultures, and if culture failure happens, you don't get results. Redraw sample didn't work out for echo-NIPS. Does gestational age differ? Oh, you mean to say, Kishore, that if the gestational age is different for the same patient, do the results get impacted? I would say no. And what would happen is it depends on the reason why it didn't work out. If it's, let's say, a noisy sample or a borderline sample, or if there's some other thing, then the gestational age would not matter. Then I would look at different parameters, pre-analytical and analytical, and we can discuss that. There are several pre-analytical factors which impact the outcome of NIPS. If it is something where the first time it came as low fetal fraction, then yes, then waiting for a couple more weeks before we do the resample can play a role. So let's say you did it at 10th week and it came as low fetal fraction, right? No call was made. Then it makes sense waiting, maybe till the 12th week or 13th week before we take a resample. And generally what happens is proactively we will communicate with you that this is what has happened and this is the kind of precaution we need to take. Even for pre-analytical factors, twice we will do the test. First, the original sample you said. Second one is the repeat sample. If that is failing, generally what we do is we say, for this particular case where it's borderline or you have a gender mismatch happening repeatedly, we'll say don't go for NIPS. It's not just with us or a type of NIPS. Don't go for NIPS here, because it's better to go for a direct invasive confirmation. And there what we can offer you is a microarray. We would say our first line in terms of recommendation is a microarray, because it does a wonderful job of looking at all chromosomes at one go, and it screens the entire chromosomal complement for microdeletions at one shot. So that, Kishore, it depends on case to case and depends on the reason why it doesn't work out. So again, it's a cell culture based assay, so cell culture is required. Here you don't need to do that. Please remember, karyotyping especially is a low resolution test. The resolution there is limited by the person looking at it. Essentially, you're looking at 5 MB or greater changes. Something like 10 MB, 20 MB, all that can be picked up. Whereas the microarray is a high resolution test. Even changes as small as 200 kilobases. Remember, it takes 1000 kilobases to make 1 megabase, right? So even changes as small as 200 kilobases can be picked up and reported. So that is something very, very interesting for us in terms of providing you more effective answers. So if you're looking at something like a microdeletion, a karyotype will not help. You're looking for a microdeletion which let us say DiGeorge syndrome. I want to specifically check for DiGeorge syndrome. So what do I do for that? I say, okay, I can do fish test. It's cost effective, absolutely. But you're suspecting that this could be microdeletion, but you're not sure. You're not sure, okay, do I look for Angelman? Do I look for DiGeorge? I'm not sure what to do. So you can't do fish for DiGeorge and this thing at the same time. You have to do fish for DiGeorge separately, fish for Angelman separately. But if you take a microarray as the confirmatory test, you're able to screen all those chromosomes at 200 kb resolution. And a DiGeorge deletion typically is between 2 to 3 MB depending on how much gets deleted. So it's below the detection limit of the karyotype, but it's very much in the range of a microarray. Fish can be done selectively, and This one will screen all the chromosomes for microdeletions. Very importantly, one point which I will be adding before I share this slides with you is we can look at epigenetic changes using a microarray. I was talking about Angelman syndrome and Prader-Willi. Most often 90% of the cases will be caused by microdeletions, but 10% of cases over there would be caused by something called as uniparental disomy, where instead of a microdeletion being present, it is two chromosomes coming from the same parent. That can actually be picked up in microarray. So that also is an added advantage here. I'm sorry I did not include it right now, but I will definitely include and send the same to you. And of course, what happens, let's say your microarray is negative, but your ultrasound is still showing abnormalities. For example, you are having cases where it's oligohydramnios, you've done the screening. If you have done karyotyping and FISH, once the test is done, then the cell culture will be discarded. It's not continued, right? Because it's an additional resource to be managed by the lab, which is not required for that. But here, DNA is available. So the same DNA can be taken. You can go for an NGS based screening. You can say, okay, Sam, I'm getting oligo. I'm thinking it could be a Denny-Drash case. Look at the nephro panel. Can you do some nephrology related gene testing for this child, for this fetus? It can be done. So that is also an additional advantage here, in that the DNA will remain with us. And you can say, look, for the previous child also, okay, we have this sample, we have this DNA with us. For next time, do we have to consider something else? You can say, Sam, look, these parents have already undergone a lot here. They don't want to do the testing now, but you have isolated the DNA, good. Microarrays come negative, okay, fine. But for next child, when they're going for next pregnancy, at that time, can you use this DNA for doing the NGS based panel analysis? Can you do a clinical exome on this? I'll say absolutely, doctor. Next time, before they plan for the pregnancy, we can do the screening for this. I'm sorry, the call accidentally went on hold for a little bit. So you can actually do carrier testing. So this is something which we very often emphasize, even in cases of where you have POC testing to be done. We always recommend that at least you can let us to isolate the DNA and store it, because it becomes really useful for when they're planning to go for next pregnancy. What does that mean? It simply means that for a POC, sure, we want to do karyotyping and FISH, sure, but also allow us to isolate some DNA and store it. Let's say the karyotype comes normal, or the 95% of the cases, what happens in POC, cell culture failed, so we have done FISH for 13, 18, 21, all of them are normal. This is what very often as clinicians you will see it. So you allow us to isolate the DNA, and when they're planning for next pregnancy, we can recommend, okay, we have the DNA with us, would you like to go for a clinical exome or medical exome screening? Would you like us to do a trio analysis of both parents along with this, so that in one shot, we are able to tell you what happened in the previous fetus, and what is the carrier status of the parents, and what is the recurrence risk. So any molecular test, this added advantage is always there. So next would be the penultimate slide in my presentation. So prenatal testing services, like I said, we have end-to-end. So we offer NIPS, NIPS plus, Karyo and Karyoplus in terms of screening. And we also offer all the confirmatory tests, karyotyping and FISH, prenatal microarray, Sanger and MLPA for variant confirmation, and we do NGS based screening for mutations, whether it's whole exome, medical exome, or clinical exome. With that, I would like to conclude my presentation, and again I would like to open the session for any additional discussion we can have right now. And if you would like to share any interesting cases or have a case discussion with us, please go ahead. At the outset, again, I would like to thank each and every one of you for taking time out of your busy schedules to join us. I would like to thank all of the ECGI members, the sales team, and Yogesh from marketing for coordinating such an activity. And we would really enjoy having your feedback after this session. You can email us or reach out to us. Yogesh, is there any other mechanism which I have missed in terms of getting feedback? You would like to add something? I think Yogesh, with his usual promptness, has given us a link on which you can rate our presentation and give us feedback. And if there are any cases you would like to discuss, like I really appreciate what Kishore has put there in terms of, Sam, look, a redraw does not work with us, or one of our cases have failed because of redraw. What do we do? This is something you would find. right? In NIPS, you sent a sample, but it didn't work, no call happened. You sent a redraw, no call happened. What do you do? So it depends on the type of no call there. So any cases like that you would like to discuss, I welcome all our guests to participate. Please unmute yourself and you can discuss, or if you'd like to put it up on the chat box, please go ahead and put it up there. And thank you all very, very importantly for your patience as well. If there's anything else, please let me know. I would keep the session open for another 5 minutes with your permission. So anything is there, please do let us know. Dr. Shefali, thank you so much for those kind words. It really encourages us to continue this, and please, along with your feedback for this presentation, do give us feedback for any other topics you would like us to present or discuss. For me, I enjoy discussing clinical cases and clinical examples, because very often in genetics, the same phenotype can very often have different genotypes. Thank you so much, Dr. Deepa and Dr. Haridas. If there are no other questions, with your kind permission, can I conclude the session? Thank you so much for all your inputs. Yes, the recording, again, I am a bit of an old school guy here, so I'm not sure. I'm recording the session. I will ask Yogesh to coordinate how to share that. He's more equipped in doing that. Is there anything else? I think Dr. Rita has, ma'am, do you have any query or any questions, ma'am, to share with us? Right. Okay. So thank you all very much. With that, I would like to conclude our session, and I'm looking forward to your feedback. And I really appreciate the participation and the questions. Thank you, one and all. I would like to conclude the session.